Hope you all will be fine. Okay, so we are starting the preparation for surgery subject. We will discuss both the general surgery and the systemic surgery portion. These are the handwritten notes which are written from the general surgery and systemic surgery book of Bele and Love, Abdul Wahab Dogar, and also it includes the important points from first aid book. So this is a very nice and perfect combo of all the important points which are references from these books, and it is perfect for the preparation of final year MBBS prof. It contains all the important points, and also we can prepare our SEQs as well as MCQs and can develop our normal concepts from these notes. So let's start. This is the index. This is the index of general surgery. The following topics will be discussed in general surgery. We will discuss one by one. We will start from shock and hemorrhage. These are the topics of systemic surgery, that is breast and thyroid, orthopedic surgery, upper GIT, lower GIT, and urology. So all these units will be discussed in this series of videos. First of all, we will discuss the general surgery portion. General surgery. Then we are having breast. Then we are having thyroid. Then we are having orthopedic surgery. Then we are having upper GIT. Then we are having lower GIT. Then urology. And so these are we will cover this all topics as soon as possible. And first of all, we will start from general surgery portion. Starting from general surgery portion, the first chapter we will be discussing is shock and hemorrhage. Let's define shock. Shock is the state of hypotension accompanied by hyperperfusion of tissues caused either by decreased supply or inability of the tissue to use oxygen sufficiently to meet the metabolic requirement of the body. So how shock is defined? Shock is basically a state of hypotension which is accompanied by hypoperfusion of the tissues caused either by decreased supply or inability of the tissues to use oxygen sufficiently to meet the metabolic requirement of the body. Now what are the types of shock? There are 6 basic types which can be remembered from the mnemonic CNS HVD. C is for cardiogenic shock, neurogenic shock, septic shock, hypovolemic shock, vasogenic shock, and distributive shock. Let's define hypovolemic shock, which is the most important and the most common shock. Okay. Particular form of shock in which heart is unable to supply enough blood to the body. It is caused by blood loss or inadequate blood volume. Okay. Why hypovolemic shock caused? It is caused by the blood loss or inadequate blood volume. What are the causes? Following are the causes: hemorrhage following trauma. Leading cause is surgical patients. Bleeding may be external or internal hemorrhage, occur in chest, abdomen, pelvis, and long bone fractures. Long bones are tibia and hemorrhage, 70 f50 of ml blood loss, femur 1500 ml and pelvis 2000 ml. Due to loss of other body fluids, this is one of the cause. Diarrhea, vomiting, burns, loss of 1/5 or more lead to hypovolemia. Okay, so there are the 3 basic causes of shock. Hypovolemic shock. There are 2 main causes of the hypovolemic shock, that is hemorrhage following trauma and due to loss of other body fluids. And there are the 6 main types in which the hypovolemic shock is the most common. What are the stages of shock? First of all, compensated volume hypovolemia. Decreased blood with no obvious signs, 10 to 15% loss, diagnosis by increased urine osmolarity and decreased sodium concentration. How we can say that this is compensated hypovolemia? When there is decreased blood with no obvious signs and there is 10 to 15% loss of blood and the diagnosis made the urine osmolarity and decreased sodium concentration. Overcompensated hypovolemia. Hypovolemia occurs to extend tachycardia, pallor, cold, clammy skin, and tachypnea. Decompensated hypovolemic shock. Reflex mechanisms are inadequate to maintain perfusion to vital organs. Decreased blood pressure, pulse disappear, bradycardia lead to circulatory arrest. So these are the stages. First stage is the covered compensated volume hypovolemia, in which the blood or volume is compensated in the body. Then the second stage is overcompensated volume hypovolemia, and the third stage is decompensated hypovolemia, in which the blood flow cannot be compensated. Now, what are the treatment options for the shock? First of all, prevention of ongoing blood loss. You have to prevent the blood loss. The second is restoration of intravascular volume. Prevention of ongoing blood loss. Treating cause, for example, external hemorrhages by applying pressure in case of concealed hemorrhage requires surgical intervention. To prevent the blood loss, you have to conceal hemorrhage. The second is restoration of intravascular volume, achieved by passing two large bore intravenous cannulas and 10 to 20 ml per kg ringer lactate. Lies flat with feet elevated about 12 inches to increase circulation. Okay, so what you have to do with the patient? Victim lies flat with the feet elevated about 12 inches to increase circulation. What are the types of fluid given? For 20% or 1 liter loss, you have to give crystallite solutions, typically ringer lactate. And for 30% loss, that is 1.5 liter loss, you have to do blood transfusion, that is mandatory. Okay, these are the causes. Hemorrhagic. Okay, what are the causes of hemorrhagic? Trauma, surgery, gastrointestinal and retroperitoneal. What are the causes of non-hemorrhagic? Burns, diarrhea, vomiting, dehydration and thermal injury. What are the complications? Organ failure can occur, kidney damage can occur, gangrene of arm can occur, legs, brain damage, heart attack and death. What are the management options? Blood sampling, cross-matching, CBC, LFTs, RFTs, coagulation profile, electrolytes, etc. These are the basic tests, okay? Intravenous fluids and plasma expanders, fresh whole blood transfusion, tetanus prophylaxis, monitor input-output record, pulse, BP and auto saturation. You have to remember all these basic investigations for each and every disease, that is blood sampling, cross-matching, CBCs, LFTs, RFTs, liver function test, renal function test, coagulation profile and electrolytes, etc. Intravenous fluids and plasma expanders, fresh whole blood transfusion, tetanus prophylaxis, and the monitoring of input and output record, pulse, BP, and auto saturation. What are the medications which we can use? These are vasopressors, and ionotropic therapy is not indicated as first line therapy. They are used if BP does not improve with fluids, blood transfusions, etc. Okay, so what we studied, first we have discussed the definition of shock, then what are the types of shock, then what are the causes of shock, then what are the stages of shock, then what are the treatment options, then how we can prevent, then what are the basic causes of hemorrhagic and non-hemorrhagic, what are the complications that can develop, what are the management options, and what are the medications. So in this portion we have our general idea that what we have to learn in the general surgery. We should know the definition of the topic, then the types, then the causes, then the stages, then the management options, then the investigations, then the medications. These are the important things which we should know about each and every disease in the field of surgery. Coming towards septicemia. Septic shock. For septic shock, first let's define septicemia. What is septicemia? It is potentially life-threatening infection in which large amount of bacteria are present in blood. Septicemia occurs when bacterial infection elsewhere in body, such as in lungs or skin, enters the bloodstream, also known as blood poisoning. What is septic shock? Septic shock is caused by infection in bloodstream in which blood pressure falls dangerously low and many organs malfunction because of inadequate blood flow. Now, what are the causes? The causes are trauma in potential peritoneal activity leading to peritonitis, newborn sepsis, immunocompromised patients, diabetes, and cirrhosis. These are the common types of septic shock or causes. What is the pathophysiology? Cellular ischemia, circulatory mediators, free radical reactions. This is the pathophysiology. Now, what are the signs and symptoms? Shaking, chills, rapid rise in temperature, falls in later stages, warm and flushed skin, become gradually cold, decreased blood pressure, rapid breathing, oliguria and anuria, indicating acute renal shutdown. These are the signs and symptoms of septic shock. Whenever a patient comes with the sign and symptoms of shaking, chills, warm and flushed skin, rapid breathing, rapid rise in temperature, this is the main symptom. Oliguria and anuria indicating acute renal shutdown, then it is septic shock. What investigations you have to do? First of all, do the CBC, the coagulation profile, lactate levels, serum electrolyte, renal function test, liver function test, and blood culture, urine culture, and imaging, that is X-ray, CT scan, or ultrasound abdomen. These are the basic investigations which you have to do in the case of septic shock. What are the treatment options? First of all, address the infection, then remove the cause, and then treat the infection. For example, if the cause is catheters, then remove the catheter, or if it is abscess, then you have to treat the abscess. Treat infection. Large intravenous bore cannula inserted. Draw blood for culture and sensitivity when cannula is inserted for intravenous infusion. Broad spectrum antibiotics are given. Therapy is specifically given after cultural results are obtained. Dealing with hypovolemia. Fluid resuscitation. First, we have to treat the infection. Then, if the hypovolemia has occurred, then we have to treat it. High risk of hypotensive organ failure, circulation should be maintained. Goal or CVP 6 to 12 mm of Hg, urine output greater than 0.5 ml, and mixed venous saturation greater than 70%. These are our goals. We have to deal the hypovolemia and we have to do the fluid resuscitation, and for that we must know what is our goal. So the CVP must be 6 to 12 mm of Hg, the urine output should be greater than 0.5 ml per kg per hour, and mixed venous saturation should be greater than 70%. Ringer lactate, normal saline, and Hartmann solutions are given. Increased cardiac output, dopamine act direct on heart, vasopressin are used in adjunct to fluid resuscitation. Epinephrine, norepinephrine, and ionotropic dobutamine. These are used for increased cardiac output. Prevention of after effect of septic shock. Prevent bed sores. Prevent bed sores. S2 antagonists used to prevent stress ulcers. Heparin is used to prevent DVT. Okay, what are the other supportive therapies? Blood product administrator, corticosteroid, antipyretics, endotracheal tube, and mechanical ventilation. This is done for the ventilatory support. Okay, so what we have studied in this portion? Septicemia and septic shock. Then what are the causes of septic shock? What is its pathophysiology? What are the signs and symptoms? What are the investigations that are done? What are the treatment options? In treatment options, first we have to remove the cause, then we will treat the infection, then we will deal with the hypovolemia, then we will increase the cardiac output, then the prevention of after effects, and then we will provide the supportive therapy. Okay, now coming towards burns. Let's change the color of our highlighter. This one is good. Yeah, I like it. Okay. Burns. What is the definition of burn? Assessment of burn, management of burn. Okay, what we have to learn in this chapter? Assessment of burn, management of burn, complications, calculate the areas of burn, calculate fluid requirement, initial management, steps in treatment. We should know this after studying this chapter. Okay, so what is burn injuries? Burn in a tissue injury, coagulative necrosis due to application of thermal energy in any form to external or internal body surfaces. What is burn injuries? Burn in a tissue or injury due to application of thermal energy in any form to external or internal body surfaces. Okay, what are the causes of burn injuries? It can occur due to flames, contact with hot sources, radiation, chemical scales, electricity, and friction. Okay, classification on basis of thickness. How we have to classify burn? We have to classify it on the basis of thickness. First of all, we are having partial thickness burn, then we have full thickness burn. In partial thickness burn, we have superficial partial thickness, then deep partial thickness. Okay, so superficial partial thickness, in superficial partial thickness burn, we have epidermis and dermis up to its papillary layer. Superficial thickness, partial thickness like clinically blistering, loss of epidermis, underlying dermis pink, no fixed capillary staining, pinprick sensation normal. How we will identify the superficial partial thickness? We will identify it will have blisters, loss of epidermis, underlying dermis will be pink, there will be no fixed capillary staining, pinprick sensation will be normal, and there will be the treatment will be non-surgical. Now deep partial thickness burns, there will be 2-degree burn. The superficial partial thickness is 1 degree, and in the deep partial thickness it is 2 degree. So epidermis and dermis up to its reticular layer is involved. Clinically, epidermis lost, exposed dermis not moist, abundant fixed capillary staining, reduced sensations. What will be the treatment option? Heal in 3 or more weeks without surgery. Now, in case of full thickness burn, 3-degree burn, whole dermis destroyed, appearance varies, no capillary refill, thrombosed vessels under skin, no pain sensation, completely anesthetized. Okay, so we have classified the burn in 2 main types. First one is partial thickness burn, that is 1 degree, and the second one is full thickness burn, that is 3rd degree. The partial thickness burn is classified further into 2, that is superficial partial thickness layer and deep partial thickness burn. The superficial partial thickness is 1 degree burn and the deep partial thickness is 2 degree burn. Then we have discussed its treatment, its clinical presentation, its treatment, and same for goes for this one and this one. Okay. Now assessment of burn patient. How we will assess or classify the burn patient? First of all, we have to do the airway assessment, then assessment of extent, then assessment of complications due to burn. So first one is the airway assessment. How we will do it? Both physical injury as well as metabolic injury, chemical pneumonitis, bacterial pneumonia, full thickness burn cause mechanical blockage to rib movement. Injury to airways above larynx, supraglottic airway burn and laryngeal edema. Injury to airways below larynx, respiratory epithelial rapidly swells and detached and decreased gases exchange. Okay, so we will assess the airways, both physical injury as well as metabolic injury. Okay, we have to assess the airways for both physical and metabolic injury. Chemical pneumonitis, bacterial pneumonia, full thickness burn cause mechanical blockage to rib movement. Okay, injury to airways above larynx is supraglottic airway burn and laryngeal edema, and injury to airways below larynx is respiratory epithelium rapidly swells and detached and decreased gases exchange. Now, what is the signs of inhalational burns? Sign nasal hair, nasolabial burns, stridor, cough, anxiety, burns inside mouth, pharynx and larynx, airway swelling, respiratory distress, serious symptom, sputum and confusion. These are the signs of inhalational burns. How you have to classify that whether the burn is inhalational or not? So you have to look for the nasal hairs, the nasolabial burns, the stridor, cough, anxiety, the burns inside mouth, pharynx and larynx, the airway swelling, the respiratory distress, the sputum and the confusion. Okay, so we have assessed the airways for burn. Now coming towards the assessment of extent, that how much burn has occurred. Okay, one is small and patchy areas of burn. Extent is assessed using area equal to patient's hand, palm and digits as 1% of the total body surface area. TBSA, total body surface area. Wallace rule of 9. For small and patchy areas, we have used the digit method. Now, Wallace rule of 9, we will apply the Wallace rule of 9 for the assessment of the extent of burn. This is very important. To approximate the percent of burned surface area, body is divided into 11 sections. In adults and in children, the separation is the distribution for Wallace rule of 9 is separate for adults and children. In adults, the head is 9%, right arm 9, left arm 9%, chest 9%, abdomen, upper back, lower back, right thigh, right leg, left leg. All contain 9%. Okay, so when we combine or we add all these, it becomes 100%. In children, the head is 18% and the all right arm, left arm, chest, abdomen, upper back and lower back is 9% and the legs and the thighs are 7%. All the sections amount 99%, rest 1% is genitalia. So this is the general classification for the Wallace rule of 9 to assess the extent of burn. The third one is Lund and Broder chart. Lund and broader chart. Length broader chart takes into consideration of age of person with decreasing percentage of total body surface area for head and increasing percent for thigh and legs as the child ages, but other areas upper limb, feet and trunk remain same for all groups. Okay, so how he classified the bun or extent of bun? The total body surface area is divided as such that along with the age, the percentage for head decrease and for thighs and legs increases. Its length increase with the age, and the other parts, that is the chest, back, abdomen and trunk, remains constant. This is the diagram from which we can learn. This is the percentage with age. This is head, its percentage with age decrease. This is chest 13%, back 13%, abdomen 5%, and trunk is 5%. This remains constant, okay? There is no change in this percentage. The upper limb is constant, while the thighs and the legs increase with the age. And the feet is also constant, okay? So these are the written here that the hand is 2, 1.5 and 1.5. The total it is 5. The thighs, the this B, C and A, where the alphabets are written, these are variable, while the numbers which are written, these are fixed. This 1.5, 1.5, this 5, this 5, and this is fixed, while the head region, the thighs and the legs, these are variable. This change with the age. The head percentage decrease and the thighs and legs percentage increase. So these are the general methods for the assessment of extent of bun. Now the assessment of complications of bun. We have acute and delayed. In acute state, there is loss of fluid leading to hypovolemic shock, acute renal failure due to myoglobinuria and hypovolemia, acute respiratory distress syndrome. While in delayed, there is malabsorption from gut due to damage to gut mucosa, ulceration of stomach, circumferential burns on limbs may cause compartment syndrome, defected immunity, bacteremia, and septicemia. Okay, now come towards the management of burn. First, we have to do the initial management, that is pre-hospital care. We have to stop the burning process, then check for other injuries with standard ATLS protocol, that is ABCDE, and a rapid secondary survey. Acute trauma life support is ATLS, and ABCD is airway, breathing, circulation, and etc. Okay. Now cool the burn wound and elevate if it is a small. Give oxygen in case of fire in an enclosed place, or especially if patient has an altered conscious level. Elevate the limbs affected and bring patient to sitting position. This is the initial management of the burn patient or pre-hospital care. Now in hospital management, what you have to do, first of all, do airway and breathing. Assess the airways. Put endotracheal tube prophylactically. If laryngeal edema present, perform emergency cricothyroidotomy, inhalational injury physiotherapy, nebulization, warm humidified oxygen, ABG's analysis and ventilation, 100% O2 in case of metabolic poisoning, sclerotomy done if large burns hamper chest expansion. In circulatory support, you have to do burn greater than 15% of body surface area require intravenous fluids to prevent hypovolemic shock. You have to calculate the fluid for the area burned from a formula known as Parkland's or Mount Vernon formula. This is very important. Everyone should remember this. Parkland formula used to calculate fluid requirement in first 24 hours. What is the formula? Percent of burn into body weight or kg into 4 ml. We have assessed that how we will assess the extent of, we have learned that how we will assess the extent of burn. As first of all, when the patient of burn come, assess the extent of burn from Well's rule of 9 or length and broader chart. You can use both the methods and then multiply that percent of burn with the body weight or in kgs and multiply it 4 ml. So the amount that come, that is the amount of fluid required for the body in or the patient in the 24 hours. Half is given in first 8 hours. Now you have calculated the amount of fluid required. Now how you will infuse it or give it to the patient? First of all, half amount is given in first 8 hours starting from the time of injury. Rest is given in next 16 hours. Okay, when let's suppose 20 ml is required, so give the 10 ml in first 8 hours and then the next 10 ml in the 16 hours. Maintenance fluid must be given to children as follow in addition to calculate fluid. For example, dextrose or saline for 24 hours, 100 ml per kg for first 10 kg, 50 ml per kg for next 10 kg and 20 ml per kg for each 1 kg or 20 kg. After 24 hours, give maintenance fluid in adults 40 ml per kg per day and in children by formula given above. Okay, now we have calculated the amount of fluid required from Parkland's formula for first 24 hours. After 24 hours, we have to give the maintenance dose or maintenance fluid. So how we will calculate it? For the children, maintenance fluid must be given to children as follows in addition to calculate fluid. For example, dextrose or saline. We are giving dextrose or saline for 24 hours. Then 100 ml per kg for first 10 kg. Then 50 ml per kg for next 10 kg and 20 ml per kg for each 1 kg. After 24 hours, give maintenance fluid in adults 40 ml per kg. In adults it is fixed, that is 40 ml per kg, while in children we have to calculate it like this. Okay. Mount Vernon formula: resuscitation duration divided into 6 periods over 36 hours. What is Mount Vernon formula? The resuscitation duration is divided into 6 periods over 36 or 1 period volume replacement. That is percentage. That is weight in kgs multiplied by percent of burn divided by 2. Okay, so we have to assess the extent, we have Wallace rule of 9 and the Lund-Broglie chart, and for the assessment of the amount of fluid we have Parkland's formula and the Mount Vernon formula. So the Parkland formula is percent of burn in body weight in kgs multiplied by 4 ml and the Mount Vernon formula is weight in kgs multiplied by percent of burn divided by 2. Okay, now coming towards the types of fluid that can be given. Crystalloids, for example, Ringer lactate, Hartmann solution, hypertonic saline, ideal Ringer lactate, composition same to plasma fluid. These fluids can be given. Treatment of burn wound. How will we treat? We have assessed the burn, we have given the fluid. Now how we will treat the specific burn wound? Treatment of burn wound. First of all, we will clean the wound and then we will dress it. Now treatment is according to the depth. If it is superficial thickness, then heals irrespective of dressing applied. Use easily applicable non-painful dressing, for example Vaseline, impregnated gauze, fenestrated silicone, sheets, etc. Dressing should be changed after every 48 hours. No surgical intervention requires. Healing occurs in 2 weeks of superficial thickness. Now if the burn is deep partial thickness, then top layer of dermis is shaved off until puncture bleeding appears and dermis is seen free of any small thrombosed vessel. Then split thickness skin graft may be necessary but can heal without grafting. Hypertrophic scar. Control bleeding using topical adrenaline. 1 ratio 50,000. Okay, this was for deep partial thickness. Now if the burn is full thickness, then generally full thickness excision of the skin is done up to viable fat. Then excision up to fascia may be necessary in some cases. Immediate skin grafting should be carried out wherever possible. This is the treatment of full thickness. Then silver sulfadiazine cream is used, that is 1% cream. Broad spectrum against bacteria, Pseudomonas aeruginosa, methicillin resistant Staphylococcus aureus. The side effects is causes leukopenia. Okay, the next one is silver nitrate 0.5% solution against Pseudomonas, needs to change every 2 to 4 hours, and the side effects are causes hyponatremia and methoglobinemia. The third one is mefenide acetate 5% cream. It is painful to apply and it is associated with metabolic acidosis. The fourth one is serum nitrate for deep burns, hard effect on burnt skin, and it improves immunity. Scarotomy is done. Coagulating necrotic skin is called eschar. Fluid and protein extravasate from tissues beneath eschar which is unyielding. Analgesia, small and superficial paracetamol, NSAIDs and hypothermia, and for large morphine, painful control 2 to 5 mg is given. For energy balance and nutrition, require high nutrition because body goes to catabolic state. In adults, 15% total body surface area, and in children, 10% total body surface area. Greater than 20% total body surface area, NG tube feeding within 6 hours of injury is given. Cover and warm patient and nutritional balance measurement. Now for infection prophylaxis, there is decreased immunity and is prone to infection, and the temperature is high, that is 38.5 degrees C. That gives us the sign of infection. So what is the treatment? Prevention, hand washing, tetanus prophylaxis, and broad spectrum antibiotics are given for infection prophylaxis. Additional measures are nursing care, physiotherapy, and psychological support. At the 8th number is tetanus prophylaxis should be practiced, and gastric decompression is done. Decompress the stomach with nasogastric tube as it will prevent aspiration. Non-thermal burn injuries are chemical injuries, cold injuries, ionizing radiation injuries, electrical injuries, which is present in the book, Burn Center Referral Criteria, and American Burn Association. These are some of the topics which are discussed in the burn chapter, but these are not that much important. If you want to give the read, then it is present in the book. So what we have studied about the burn, which are the most important. First we have defined the burn, then what are the burn injuries, what are the causes, what is its classification. Classification is partial thickness burn and deep thickness burn, 1 degree, 2 degree, and 3rd degree. Now how we will assess the burn patient? First we will airway assist, do airway assessment, then we will assessment for extent. The methods for the assessment of extent are Willis rule of 9, London broader chart, and for the assessment of complications we have acute and delayed. In management we have to do first the initial management, then the hospital management. In hospital management we will first do the airway and breathing, and then the circulatory support. For circulatory support we have to give the fluids, and we have to calculate that from Parkland's formula and Mount Vernon formula. Then we will, what types of fluids can we give, then what is the treatment according to the depth, that is superficial and deep partial thickness and full thickness, and what are the creams that can be applied, that are sulfadiazine, silver nitrate, mefenid acetate, and serum nitrate. Analgesia is given, energy balance and nutrition is applied, infection prophylaxis is given, additional measures are done, tetanus prophylaxis is done, and gastric decompression is done. In the next video, we will discuss about the blood transfusions. Thank you.